Good morning, everybody, and thank you for joining us this morning as we strive to translate years of dialogue with the WFH through the Changemakers series and change that into tangible actions for two things, better diagnostic and optimized care throughout the world. Yesterday, at a breakfast with the president of the WFH, we were joined by advocates and changemakers from across the world to change strategies and best practices that could be implemented globally. And we heard from a number of leaders, of which, my little thing fell off, from a number of leaders from their experience in their respective countries. James Kago from Kenya explained how the community champions, which are roles that they created with the Hemophilia Foundation in Kenya, have brought on board, for example, the first wives in the counties throughout Kenya and engage with them and actually transform them in advocates for the cause of hemophilia in Kenya. He also shared how patients and their families systematically partner with clinicians as they engage with key stakeholders to make their respective voices stronger. We also heard from Baiba Zimele, a patient leader from Latvia who's recognized beyond Latvia, on the importance of building bridges with other rare disease communities for a stronger voice and make the voice of patients heard much louder. She also emphasized how change starts with every single individual knocking at every single door consistently and persistently, and called for action, every single one of us, to speak up for women and girls with bleeding disorders. Today, we have with us a distinguished panel member, Chris Bombardier, who will share his experience in his region and beyond. And I'm honored to co-chair this session with Cesar Garrido, the president of WFH. So thank you for that. And without further ado, Chris, maybe you can present yourself. I've called you Chris from the Everest, but you can explain more. And explain where diagnosis is standing in the US and beyond.
Yeah, so hello everyone. Really excited to be here and get to share a little bit of my experience and story. So I was diagnosed with severe hemophilia B at birth. We had a family history of hemophilia. My mother had two uncles who had passed away before I was born. But we were lucky enough to have at least that generational awareness of hemophilia in our family. So my mother knew at least to have me tested when I was born. I also have an older brother who was tested, no hemophilia. And then I was born 2 years later, the lucky one. My mom is also a little short, so I make a few jokes to her that she gave me short and hemophilia, but she doesn't find that very funny. But I think being diagnosed at such an early age and getting connected to an amazing hemophilia treatment center in Colorado was a hugely transformational and really fortunate occurrence for me. I was visiting a treatment center that always really believed in letting people with hemophilia, experience life and try new things and try new challenges. And they always encouraged me and worked with me to, I at first started playing baseball at a young age and played through college. And then I started, getting into more outdoor activities like mountaineering and climbing. And they, instead of saying like, oh, you have hemophilia, you can't do that, it was more of like, how can we work together to make that possible? And it was really amazing to get to, still have those life experiences as a person with hemophilia. But it's also, I think, really important to note that like that story for me is true in the US, but it's still not true for everyone in the United States. We're still having struggles for diagnosis for, mild hemophilia, especially women and girls getting diagnosed with bleeding disorders is a huge challenge. And then we have also a lot of rural communities in the United States that have really challenging access to healthcare and good diagnosis. I used to go to a summer camp in Alaska, and there are some, boys, native Alaskan kids that could get there by a tiny bush plane part of the year and snowmobiles the rest of the year. So there's still a lot of challenges in that sense in the United States. But then I also get the honor to work with Save One Life, which is an international nonprofit, and I get to see that diagnosis rates around the world are extremely challenging. Just talking to some folks today about only having 100 people diagnosed in their entire country when they should have several thousand. So it's when I get to reflect on my story, I recognize the privilege that I've had of just being born where I am, and how much work we need to keep doing to help other people have that same experience, hopefully.
Caesar?
Yeah, well, I remember that I was talking with you about because for many people in the world, we think that in the United States you don't have problems. So you were a lucky man because you received an early diagnosis, you received the support and the assistance from the healthcare professional and your family. But I insist that what happened with that is an equal situation in whole United States, or you have several towns or cities that maybe are not so lucky like you.
Yeah. So I was born in Denver, Colorado, so a big city, and I guess I'm a little biased, but I think some of the best hematologists in the world. Marilyn Minko Johnson was my hematologist, and I think she's a legend. But not everybody gets that experience. I have friends that also go to that same treatment center, but they live in Montana, and that's like a couple hour plane flight or an 8 to 12 hour drive to get to a treatment center. So yeah, I mean, it just really depends, where you're born, what kind of hematologist around, how quickly you are diagnosed. And then, I got to go to the treatment center every time I had bleeds and get physical therapy. And, I had my nurse and physical therapist came to my, high school graduations and weddings and stuff. So not every place in the US has that. And I think, obviously that's the goal, is to have treatment like that. But yeah, there's still lots of work to be done, definitely.
I wonder, how do you feel when you are climbing those peaks that no any member of those that you have mentioned around you, you are alone, in several cases maybe alone, isolated.
Yeah.
What kind of the thinking you have, because you receive education, training, and the medicines as well, but what kind of the thoughts that you have in those moments related to hemophilia?
Being on the mountains and stuff?
The top of the height.
There was a couple moments on Everest where I thought that it was kind of maybe not the best idea. But, I in those moments, I always thought about the preparation and training and all the planning that went into those experiences. And it wasn't like a random decision or a split second decision. It was a long process of preparing and working with treatment center and climbing guides and training myself for that kind of situation. But there were a few moments where I was questioning my sanity of being up there.
Anybody would.
But there was also on Everest particularly, I carried a flag up that was signed by all the people in Nepal that had hemophilia and that I met in the community. And that gave me a lot of energy and power to know that there's a whole community that was there to support me, and that is a big family to me. So that was a really powerful moment.
So it's very curious if you see, for example, those peaks are in Asia where the situation is totally different. So Chris was born in Asia, for example, they won't have a early diagnosis, and that is important really. I remember when visiting our partner and friend in Nigeria, Megan told me that one of the concerns was to receive the diagnosis earlier, because it's the joint are being affected when it's diagnosed their boys. So that is something that is too different, and we hope in short time could be improving thanks to the medicine and the new therapy available. This is possible.
There are parallels actually between being alone high in a mountain and being alone very remote. We've heard from many of the advocates and leaders in the countries that one of the major issues is the remoteness. Yeah. And so there's quality care in the bigger cities and bigger centers, but it's how do you bring the population from the more rural areas, or in countries like some of the ones you support with the PAC program, where in some seasons, no road is open because they're flooded, or I mean, in Nepal, a number of areas, they're literally closed by monsoon or snow. But I mean, in Malaysia, it's different. It's monsoon mostly. But so we have also heard how the local advocates raise awareness, educate the local community so that they recognize symptoms and go for diagnosis. And then educate and train the lab techs, the physicians and clinicians to actually being able to diagnose.
Yeah.
So maybe we can hear more from what the WFH or others are doing.
Yeah, one of the challenges, for example, when we approach any country, we define we will work with this country, and that country, for example, Indonesia. Indonesia is in many islands, something like 1,000 islands. So it's too difficult to train
Everyone.
healthcare providers in each island. In those cases, we have had the experience that we train a nurse, and when the nurse receives this capacitation and this training, maybe she or he is thinking to move to another country because the salary is really low. So that is one of the challenges as well. The other one is that how to convince the authority in this kind of country that the huge population, I'm talking about maybe more than 100 million people, so how to convince a national government. The solution for them has been more to convince the local government. I mean, the county or the province, and later could be possible gather more people, more demand, and be possible to at least approach the national government.
And build the evidence.
And build the evidence. I have been a witness that with the evidence, scientific evidence, has been possible to convince the authority. The first step is the director of the hospital. So because hemophilia is not the priority in terms of the budget, but when the director is convinced that with the scientific evidence is cheaper or is more economist to care
Treat.
those patients, he or she noticed that it's a convenience to address money and budget for hemophilia in this case.
Chris, do you want to step in?
I was just thinking back to kind of my first experience that I ever had in the kind of global hemophilia community. And I was really lucky. I have a background working in a hemophilia research lab, which is kind of random. But so I was working in this lab, and I got the opportunity to travel to Eldoret, Kenya, back in 2011. And it was a really interesting experience. There hadn't been, treatment center established there yet. There was no diagnostic laboratory there yet. But for me personally, I had never really seen what hemophilia looked like outside of my personal experience in the U.S. And I'll never forget, the first day we were there, we met a young boy who was 14 years old who had been in the hospital for like 2 weeks. 2 weeks having this massive bleed, and it was very clear evidence that he had severe hemophilia, and it was just such a huge wake up call to me. Like, he's 14 years old and he had no idea that he had this condition, the same condition I had, and I remember working on that project, and I kept going back 3 or 4 years in a row, helping to establish this lab and start diagnosing people. And just realizing like how powerful it is to give people that knowledge of what they actually have, but then also working with the whole hospital and providing education and building those relationships with that hospital to how now I've heard that treatment center is doing fantastic and has been treating over 100 patients in Eldoret consistently. And I think watching that committed effort from a group of people and how big a change it can make for these patients with bleeding disorders is really, really profound and amazing.
Yeah. Well, I think that, for example, when is it possible to give medicines to these patients in those remote areas, one of the aspects that we have to consider is what happens if we ask them or we propose them prophylaxis, because that means that they must be really very educated.
Yeah.
But the point is how to get the medicine frequently, every week or every 2 weeks or every month, depending what kind of the therapy has. So that is also the challenge. I remember when I visited Kenya, Nairobi, a guy living in a slum, very poor condition, but for him was very difficult to receive the transportation going from the slum to the hospital. So he had to learn how himself in cells infusion because it's impossible. But I noticed and I proved that exists the possibility. So there is the light at the end of the tunnel nowadays. If you ask me a similar question 5 years ago, 7 years ago, my answer for sure would be different. So Africa is impossible. I am a witness, it's possible. It's possible. But we need to be supported by the leadership. It's essential, the leadership. It's essential, the therapy. It's essential, the medicine. But without the leadership, making advocacy is something that it will be interrupted.
And Megan Aderidan, who helped prepare this event, who has been instrumental in pushing for optimized diagnosis in Nigeria, is a perfect example of it takes one to start.
Yeah.
And it's almost like a train the trainer program. It's like you talk to several people, these will continue to kind of share the information, and it kind of permeates through the system somehow. And Nigeria has made huge progress in that regards also, correct?
Yeah, I have been in Nigeria and Kenya as well, and I was impressed and I learned that the first step is to convince, as I told you, the hospital, well, to identify the hematology leader, and in those specific cases, Nigeria and Kenya, it's impressive when you see, for example, a big hospital that usually every day go 10,000 people, something like that. How is possible to observe in the main site a hemophilia treatment center? So that means that the medical leader convinced the authority of the hospital,
Absolutely.
you have to build a hemophilia treatment center. That means a lot.
And it creates the framework for better care.
Well, yes, and these two specific cases, I noticed that the work between the medical sector and the social sector, the lay member, the leader, working together, aligned together, working together, has been possible to improve. And it's not whole solution, not yet, but the forecast is that they will reach a better position and improve the condition of the patient. When the rest of the audience, the rest of the province notice that this is happening in this hospital, they emigrate to this hospital. That's another challenge. So the strategy is to try to create a network, at least with 2 or 3 or 4, depending on the population and the geographical territory, to create another, maybe a second hemophilia treatment center. Chris, you have any experience because you have been traveling in those places?
Yeah. Yeah, I feel very lucky that I've got to travel and meet so many amazing bleeding disorder communities around the world. And what I always find and notice where I feel like a lot of progress is being made is when the physicians and the medical community come together with the patients, and they do the advocacy together. I think the medical professionals provide a wonderful information about how to treat the disease and the importance of all of that, but the patients bring the stories and the personal connection that often is so powerful when you're speaking to either government officials or heads of hospitals, to really understand what it's like to have a bleeding disorder in this country and show it. And but it also requires a patient population that's educated about their own bleeding disorders, to be able to convey that message really effectively. And I've gotten to see that in a few places. I was just in Pakistan, and I feel like a couple places in Pakistan, they're doing a fantastic job doing that together, advocating for care and getting better access to newer therapies, which is really tremendous.
Now, when you are talking about the Pakistan, come to my mind experience, a very uncomfortable moment when I shake the hand of the boy who received a cryoprecipitate. So when I asked about the security of the box, well, the answer was, we don't know. We don't know because we don't have the reagent in order to make a appropriate screening. So our proposal was, as a part of the humanitarian program, to give them the novel medicines, so the very effective, extend the life or something like that, in order to give the guarantee. But the hospital depends on the budget of the federal government, and the federal government has the idea that it's cheaper the bag of cryo. So when we share with them that exists the possibility it could be cheaper because someone has to pay that bag of cryo, well, that is part of the strategy that we are implementing now in order to convince them. But we need scientific evidence. So thanks to humanitarian aid, it has been possible to gather enough information in order to prove so effective these medicines are. The first impact is that it's too expensive, but they don't calculate what means expensive. So it's more expensive, that boy receiving cryoprecipitate, and really was impactful photo that I had with them. So that is a very comfortable memory that I have about that.
Imagine.
Yeah.
Before we wrap up, are there questions from the room?
Cesar, you mentioned that it was very important the leadership. So it was very important the leadership. So for a clinician that is in a low income country, like what is the first thing? Like where to start?
Well, it's a good point because usually we talk about leader is someone who is not the healthcare provider, but it's not true because we need that the hematologist you have behind, in front of you, one of them, they are leaders as well. So in many cases, we have NMOs, our NMO, National Member Organization, I mean the organization of this country, the president or the chair is the hematology, who assumed the responsibility at the beginning. But of course, he or she will be an employee of that institution, of that system. So in several cases, they are afraid to defend or to make advocacy or to assume any position against to the director. So that is one of the aspects that we need the social leader, a part of to be employee of that system in order to be more clear and fair, of course. But I propose to assume a leadership not demanding, is proposing something to the authority, how it's possible to help them to make a decision, the right decision, how it's possible to save time, to save human resources, to save money. Because at the end, it's something that means more effective than the therapy that they are doing, appropriate therapy.
Okay, thank you for this presentation. I'm Nawal from Sudan.
Yeah.
I just want to share with you that to convince the authorities that to have a product is less costly than this crop precipitate because we learn it in a very sad way. Now we are through the last year we are going through this war. So during this. To make the cryoprecipitate available because at first days we were not able to have a single vial of CFC. So we should treat the patient with this cryoprecipitate. So to prepare this cryoprecipitate and electricity, there was an issue of electricity, issue of the bags, issue of donation. So the experience, the pain of preparation this cryoprecipitate. So now we have a live, we have a live answer of how expensive is to. I think when war stopped by hope recently, so we are ready to convince them that it is more less costly to have the concentrates than to prepare a cryoprecipitate. Thank you.
I couldn't quite hear a lot of that. I'm sorry.
That was too difficult, but I think that she's making something related. They are afraid that, and they have fear in order to give this kind of the treatment and how to do it because obviously the use of the cryoprecipitate means survivor, of course, is something that you have to do. But the risk is you don't know or you estimate what will happen for that patient, of course. So I insist. So someone pay for the cost because that has a cost. The bag, the procedure, the testing, the screening, that means a cost. Someone has to pay. In several cases, you can calculate it's more expensive than the available products and the market. So that is something that, of course, you will need scientific evidence, all right? It's possible to support you through WFH, for example. That's one of the very useful supporter. And at the same time, the leadership, okay? Someone assuming that as a leader to propose something, and it's possible at least to create a pilot project, to set a pilot project.
You know, maybe during the last month, we have a city, it's on the focus of the conflict. So even when we receive the donation from WFH, we are unable to reach that region. So they have to prepare the blood bank, to prepare the people, to prepare the electricity. So really, they sense that how it is costly. It is to prepare, to provide the patient with a cryoprecipitate.
Well, I suggest you to create, to design a plan, a pilot project, a small population with the idea to be successful in order to reply that in several places and with a bigger population.
And maybe this makes a beautiful conclusion to the event. I'm sorry to be a nasty
the
one
time.
to close, but it's actually exactly what the Changemaker series wants to make happen, is translate thought into action. So here we are with action in action.
Yeah, that is something that I recommend you to keep in mind if you want to know even more about this. This has been 2 years working together with Chris and our supporting and myself, our experience. And I recommend you the Hemophilia Changemaker series that is recorded several sessions, so this is available for you. You can scan the QR, and if you have any interested in the session yesterday, the breakfast with me was very interesting, or this one, for sure you can scan here and to get more information. And please share with us your experience as well. Thank you.
Thank you.
Thank you.